Good morning, everybody. Right, so I think we'll get started. If I have to leave in between, I told you I might have to today. So the moment they call me, I might. But for now, let's go on. We carry on. We are still discussing hand instruments. I think we did talk about dividing them into atraumatic or non-traumatic. We divided them into traumatic and we divided them into semi-traumatic, if you remember. And we had given you descriptions of how to differentiate these three and descriptions of how to use them. We had talked about the different sizes, the types. So we describe instruments based on the diameter, based on the tip of the instrument, based on the handle. So we know we have a ratchet handle for graspers, but we have a non-ratcheted handle for dissectors, scissors, etc. The ratchets are of different types, so that's just for description, but this is a bottom ratchet, okay? Then you have some in the handle ratchet. So they're different. That is not important. It's just for you to understand. The instruments definitely are rotatable. They are dismantleable. So they're called modular instruments and they can be used accordingly. Now let's go to scissors. So scissors, remember what we said, they are divided into they are supposed to have a non-grasping handle, okay? You don't have a ratchet handle. Now, how do scissors cut, if anyone can explain? So, when you take a scissors and you are, just to understand how a scissors cut, you are trying to cut this. So as you cut, first you would take this and the scissors blades would come in touch with the thing that you want to cut. Am I right? Tissue that you want to cut. So that's called engagement. It engages first. All right. Once it has engaged, then when you press it, it first causes some sort of elastic deformation. So an elastic compression. Then it will reach a point where the tissue cannot be compressed any further. It causes a plastic compression of the same tissue. And then it will cut. You've understood? So it doesn't cut immediately. So you see this, when you're now doing that, it's now causing elastic compression, now plastic compression, and then tuck. You understand? And it's cut. So this is how a scissors cuts. Secondly, most scissors cut from proximal to distal. Have you seen what I'm saying? It will cut, if I'm doing this, it will cut from proximal to distal. So these are 2 points that I need you to understand, proximal to distal and how a scissors cuts. And that's why you can see experts use scissors for many things. They'll even use it to tease, they'll even use it to open, but it's because the amount of pressure they apply will be different. You've understood. Another tip about using scissors well is try and use them with the tip more than going to the fulcrum. The moment you go to the fulcrum here to use it, you start damaging the scissors, all right? So most scissors, if you want them to, will be cutting at the tip. So these are simple tips on how to use these scissors. Now they are divided into straight scissors that ideally is used for cutting the sutures, all right, like in open surgery. Then we have the curved scissors or the tissue scissors, the Metzenbaum scissors, and these are the ones that we use for tissue. And then we have a hook scissors. Now, the difference between a hook scissors and a Metzenbaum scissors is the way I told you. Most scissors cut from proximal to distal. The hook scissors cuts from distal to proximal. Can you see that? So why is that important? It depends sometimes on what you're trying to cut. So let's say this way, you see, I'm cutting it from here to that way, okay? Now, let's say there is a very fine tissue somewhere like a ureter. So you go there, you have a ureter here, you go and touch with the hook scissors, and you go and hold what is maximum, and it will cut backwards, not forwards. Have you understood? So you have less risk of going close like this to the tissue. You go where you want, hold it, and then it cuts backwards. You've understood the difference? So it can be used for such type of scenarios as well, okay? We now obviously will also, this is instruments. Let me look for another one where we have all the different instruments. These are all instruments. This is just to show you a few pictures. So we have the types of grips. I told you over grip and in grip. We have the T-ratchet, the bottom ratchet, the ring handles. Okay, so these are just a few pictures. The graspers that are, the dissectors that are used for dissection. Okay, the scissors, as we have said. We have these are again, semi-traumatic. Okay, they are less injurious. We have the ones that are non-traumatic, and then we have the claw 2x3, 1x2, 3x4, remember? That have the teeth. And you can see this is one active, one moving, one straight to make it stronger. You've understood? So these are things we had already discussed. Then there are these others that we discuss about. We said there's suction cannula and so these are just examples of other instrument tips. These are what we call the retractors. We have the hook, which is an energy device. We'll discuss about it. We have actually clip applicators. So these are examples of the instruments, okay? Now, when you are doing these instruments, obviously we can learn these one by one, and there are very many. When you are checking an instrument, what do you check? So when I give you an instrument and I let's say it's due for maintenance, or you are setting it up, or what are you going to check? You're going to check a few things. Number one, you're going to check the handle. So checking involves checking the handle and seeing that this handle is fine, it's working, it's, assembled well. So handle, you always check the insulation. So don't try and use an instrument once it's used for another case without going through the insulation check. If you see this black broken here, then that instrument should be earmarked for two things. One, risk of blood seeping in and getting infection. And secondly, risk of energy, mishap. Because if you connect monopolar here and there is an insulation break, that's a problem. Okay, so when we are discussing the energy and talks on electrosurgery, I'll explain what that could do, but it could be disastrous. Okay, the third thing you check is the assembly. Is it fitting well? Is it working? So once you have checked, you will have to check the assembly very well. And fourth is you check the jaws to see that these are working well, they are not dirty, you get what I'm saying? So this is what a check of an instrument should look like. It's important to understand that for instruments of this nature, which are modular, which means they are dismantleable and brought back together, you don't ever clean an instrument in an assembled state. You have to disassemble it to clean it. Are we clear? So that is very important as well. Another instrument we have is the needle holder. Okay, so these are needle holders. We'll discuss about what a typical needle holder should be like, or an ideal needle holder should be like. A needle holder is usually not dismantleable because it's a very strong instrument. It has to hold a needle, pass it through tissue, make knots. So the moment you break it up like this, it can sometimes not be as strong. Okay, so it's usually not dismantleable. Most needle holders will have one moving arm and the other one not moving, again to make it strong. The needle holder could be described on the tip, so you can get a curved tip, a dolphin tip, a tooth tip, a straight tip. You get it? So that is in the needle holder. So when we talk of an ideal needle holder, yes, its ideal is not dismantleable. Ideal is single jaw action. Ideal is, it is usually light. So there are some that are very heavy. Yes, heavy does not always mean stronger. So it's good to have a light needle holder. Needle holders are usually not insulated. Okay, needle holder is usually going to have, the color, like this is shiny. But an ideal needle holder would be a bit matte finish. Right, matte, because you don't want the light that of your scope shining off this thing all the time and reflecting. You'll get, disturbances in view. So a little matte finish would be preferable. The needle holders can be divided based on the handles into a straight grip or a pistol grip. So there are different grips of the needle holder. And we said about the type. The needle holder has ratchets here, not ratchets, the serrations here, and these serrations are crisscross so that they don't allow the needle to slip. All right. In the graspers, you will mostly get sometimes that they are just straight. So this is crisscross so that they can hold the needle properly. Okay. So this is about needle holders, and they always, ideally ones, they should even have a cleaning port. Like this one has a cleaning port so that you can flush any blood that comes in this channel. You get it? So you can clean this better with a cleaning port, because you can't dismantle it, so you need a cleaning port. Understood? So this is about needle holders. Any questions so far? In the needles, in the instruments, anything that you might have had? So obviously instrument care and sterilization is a different topic. We'll see when to cover it, but for now, I think I've covered most of the routine instruments that we would use, okay? What is not covered is equipment. Now that is where I was supposed to go to theater and demonstrate. We'll do it the next visit, where we look at the insufflator, the camera head, the camera processor, the electrosurgical unit, that kind of thing. So we'll look at that next visit, okay? Okay. So we'll start with something called ergonomics. We will cover the port placement and access in the next topics. Ergonomics is very important. I'm sure I'm not going to be able to finish ergonomics talk today, but it's very important. When you people are learning the basics of MIS, it's important to learn the ergonomics as well. Now, what is ergonomy? All right, ergonomy is to ensure that you suit the work to you as well. Okay, how best to suit the work and yourself to each other, so that we don't have any injuries and to make it easy for us. Okay, so there are a few principles in ergonomy that we are going to be discussing, but at the moment I'm not going into that slide first because we'll be covering it one by one. But it's important to understand that laparoscopy is very good for our patients, and we've discussed all the advantages for our patient, but laparoscopy is much more demanding for us as the surgeons. Okay, so we have to make things better for ourselves as well. I mean, it's good to always think of the patient, which is what we do. But what if you don't think of yourself and your career as a laparoscopic surgeon is only 5 years? There's nothing you've benefited there. You understand? So to understand and do well, you have to know what is the concept of ergonomics. You have to understand what are the problems around laparoscopy that we should be looking at. You have to understand how to assess any damage that is developing. I am a living example of someone with lots of damages around laparoscopy. Why? Because I was not taught this. I learned laparoscopy. I worked as a laparoscopic surgeon. And a few years down the line, I started realizing I was getting different types of aches and pains and injuries. All right? I'm not allowing that with any of my new students anymore. Okay? So you learn this from the very basics. So it's very important. And how to manage it or to prevent it. So what is ergonomics? Ergonomics is derived from ergon and nomos, which is natural laws or arrangement of the work. The science of best suiting the worker to his or her job. Okay? So this is what we are focusing on. There is a task, your workplace, and your tools, and how to merge these three to get the best out of it is ergonomics. Okay? Why ergonomics? If you look at this person is a very simple thing. This person is moving the bin from point A to point B. There are two ways of moving it, right? There's a way of lifting it and moving it, and there's a way of pushing it and moving it. So you can see what I mean by what is easy and what is hard. All right? So that is ergonomic. This is non-ergonomic. Are we understanding? Yes. So this prevents you from getting injured. It optimizes your productivity. You could do much more, and increases your comfort. Okay? Look at this picture here, for example. I mean, whom do we say would be the most ergonomic person here? Huh? The anesthetist. You see, I guys are standing like this and relaxed position. Actually, everybody else is in different positions, looking up, looking that way, this way. That's not ergonomic. You get what I'm saying? So we'll go into how to improve it. History of ergonomics. In the 18th century, doctors noticed that workers who required to maintain body positions for long periods developed some musculoskeletal problems. But in the last 20 years, we now found that in research that there was a clear connection between certain jobs and certain types of injuries. Okay, so occupational hazards. All right? And that is because of repetitive stress injuries or musculoskeletal injuries. And then there was a paper that initially came up in 2010 saying that there was definite physical strain at laparoscopy in more than 87% of the cases. So this is what I was saying. In open surgery versus laparoscopic surgery, the ergonomic ceiling is much lower in the laparoscopic surgery. What does ergonomic ceiling mean? It means you have to keep your ergonomics every time at hand. If you want to do laparoscopic surgery, you sway a little bit out of there and you'll get an injury. Whereas in open surgery, it's lesser required. Are we understanding? So we are going to now discuss a few principles of ergonomics. Principle number one, straight line principle. So to work ergonomically in laparoscopy, try and follow a straight line principle. So what does that mean? Your position, the pathology position, and your monitor, preferably in a straight line. Okay? So don't be operating this way and have the screen that way. That's not straight line position. You will have a problem here. You've understood? Because you're going to be operating for long, you can't do this for long. So you want to be relaxed, you want to have a straight line principle. So it means that is very important when it comes to your port placement. So you'll have to have an idea of the pathology beforehand. You'll have to understand how I'm going to put my ports and hold my instruments, how my assistant is going to help me by putting his or her port. You've understood? And how I'm going to position my screens. Now remember, I told you what an ideal position or setup of a theater was. It was supposed to have ideally 3 If you need a third assistant, second assistant there, ideally 3 screens. Next ideal, 2 screens. One for the surgeon, one for the assistant. You've understood? So, below that is suboptimal. But if you have to, then you try and bring it in such a way that it's between the legs so that both you and your assistant don't need to turn so much. So don't go only towards the surgeon and then leave the assistant to be doing this. And I tell you, I mean, correct me if I'm wrong, these things happen even now, where the assistant is just supposed to look that way, right? Because the surgeon needs it in that position. And that's very unfair. That's what I would say. Ergonomically, it's very unfair. By the time you're done, this or this or this is already aching. And this is one surgery. How are you going to manage multiple surgeries? You understood? So straight line principle is one. Second thing, try and have your visual axis and your motor axis as the same. So visual axis is this axis, and motor axis is this axis. You've understood what I'm saying? It's something like the straight line principle, but it is axis of your view to axis of your action. Try and have it similar. Yeah, guys, I'll have to leave now. I'm heading to theater. So I know we had this planned for now, but yeah, the emergency is not going to allow me to continue. I shouldn't take too long, but then I know by 8 we'll anyway break up. If you want me to take it to 8:30, no, but let's do it. Let's do it next time. Let me not sure. I'm still starting. I can't. Let's not predict things. Okay. So let's meet next week. Mostly again Monday. That works with, yeah, at least works with my team. So Monday we'll continue with this. Finish the one in theater. So Monday you can come with your scripts. Okay. And then. So you pass it on that you come with your green scrubs. We'll move into theater unless we have a case in the morning. We don't want also to barge into a theater that is being used. So we'll come early, 6:30 maybe there is none, but if there is any change, I'll let you know. We might start here and then go there when it's a bit free. Okay, so Monday tentatively come with your scrubs. Okay, and then we'll finish that, come back here and continue. All right, thank you guys.